Welcome, everyone, and thank you for joining us today. I am Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have just a few housekeeping items to go over before we begin. Next slide, please. First, please remain muted to minimize background noise and interruptions. You will have an opportunity to submit questions using the chat feature today. You may submit questions at any time during the presentation, but we will wait until the end to answer questions. Today's webinar is being recorded and will be posted to the forum website for future reference. Next slide, please. A survey link to an evaluation form will be included in the chat and in a follow-up email that you will receive after the webinar. We would very much appreciate your feedback. Let's get started. I'd like to introduce Dr. Daniel Landry, who is Forum President. He has some introductory remarks for us.
Thank you, Kelly. And thanks everybody for being here today. As Kelly mentioned, my name is Dan Landry, and I do have the distinct honor of not only being the president of the National Forum of ESRD Networks, but also being able to introduce today to everyone Dr. Kam Kalantar-Zadeh. Kam's a great friend and a dear colleague, and we're so excited to have him give this talk today. So as you can see here, and I hope that maybe many of you have been maybe on our first webinar, this is our second, but we've established this Dialysis Leadership Medical Director Series from the work that the forum's done over the years. We're a group of volunteer physicians, amongst other people who make up the forum. We support the ESRD networks and the care of patients throughout this country. And we put together over the years a lot of work, a lot of toolkits, as we refer to them, in terms of education material for people so they can uh, provide the best of care for our patients. Next slide, please, Cam. But this directorship series has been named after one of our former presidents, Don Maloney. He's here with us today, and we're so happy to have him here. But I think Don, much like Cam, and I see others here as well. I know Dr. Howard, but they really highlight the fact that what we do here at the forum is volunteer work for the betterment of care for our patients, as well as for the betterment of support and education of our people in the nephrology community. As you can see here, we have a host of 9 separate talks that will be given over the next several months. I think Kelly mentioned maybe as well, but you can scan here if you wish and register for each and every one of these individual talks. We really encourage everyone to attend. They're free, of course, and they'll also be recorded, so you can come back to them later if you wish or share them with other people. Next slide, please, Cam. And one other thing I also just kind of wanted to mention as well is that the forum and our efforts to provide education will also be at the annual dialysis conference coming up in just another week and a half. We'll be giving several talks there, and we're really excited about it. And for those who can, we certainly encourage you to register as well. And next slide, please, Cam. And at the the annual dialysis conference, as you can see here, we'll be giving different talks related to the dialysis regulatory landscape in terms of compliance and regulatory essentials, as well as navigating that landscape through different growth strategies with quality metrics and such. So, oh, that's fine, Cam. You can go to the next slide. But again, I think we're really excited about, something we really try to educate our colleagues about nationally and internationally, and something that we're just honored to be able to attend. All right, Cam. So without further ado, it is, as I said, my great honor to introduce you today, Kam Kalantar-Zadeh. He is a professor of medicine at UCLA, and he's a clinician as well as as I think everyone here knows, an incredible researcher in areas such as kidney dialysis, nutrition, and epidemiology. He's triple board certified in internal medicine, pediatrics, and nephrology, and he serves as the nephrology chief at Harbor UCLA Medical Center. He's the immediate past president of the forum. He serves on our medical advisory council representing Network 18, And as I mentioned, he's one of our leaders, great friends, great colleagues. And today he'll be obviously speaking to you about dialysis leadership, and we can't wait to hear about it. So, Cam, the stage is yours, and thank you again for being here to give us this talk.
Well, thank you so much, Dan, Dr. Landry. Dan or Dr. Landry is our presidents of the 18 congressionally mandated ESRD network organizations that have created a coalition called the National Forum of the ESRD Network. And I think almost all the slides will have this wonderful logo of the National Forum of the ESRD Network. Okay, the laser is working here. And I assume that for those who would like to consider involvement or contributions, please feel free to scan this link. And as well as please spend some time to pay a visit to our website, esrnetworks.org, as well as the social media, Facebook, Twitter, X, Instagram, LinkedIn, and YouTube. So without further ado, I'm going to start today's presentation in the next 40 to 45 minutes so that we can have towards the end 10 to 15 minutes for discussion. I would like to go over the topic of physician leadership and governance in dialysis units. Now, you may be surprised to know that while this is an important and relevant topic to physicians, in particular nephrologists, it's even more relevant to non-nephrologists and non-physicians. To that end, the nearly 60 colleagues who have joined would be very beneficial if you could pay attention, write down your comments, and towards the end we can have a discussion. So what is conditions for coverage? CNS conditions for coverage is the framework for dialysis governance, as shown here. Key message number one: federal regulatory standards govern all U.S. dialysis facilities. So U.S. dialysis facilities are not under state, but they may be also under state purview and surveillance, but they are a priori under the federal government. That's very important. I say a major distinction between this and many hospital-based regulatory oversights that are state-based or even county-based or city-based. The second one is that medical director is responsible for dialysis quality and outcomes. The medical director, and that's the role of the physician. Now we come here that federal regulatory standards for dialysis centers define the requirement for governance, leadership, QAPI, that means quality assessment and performance improvement. We'll talk more about QAPI, but then, and patient safety. Patient safety, patient safety. It's never enough to repeat that because they all serve one purpose: patient safety. The conditions for coverage are required for Medicare certification reimbursement. Your dialysis clinic will not be operational if the dialysis facility does not meet the conditions for coverage, and the physician leadership is central to the facility accountability and regulatory compliance. Now, going back over the history, which was covered already last week by Dr. Andy Howard, one of the wonderful, renowned experts, that more than 50 years ago, Medicare or the so-called Social Security Act under the CMS, which is now is called CMS, the Medicare came up with the ESRD program, which I personally call it as the first and last socialist medicine the United States has ever had, the first and last socialist medicine. Why? Because it covers anybody who has a disease called ESRD. It's not ESKD. There is nothing wrong to say ESKD, but so that you know the statutory and accurate term is ESRD. And if in the court of law you mention ESKD or in anything regulatory wise, that could become a violation. But ESRD program was established in 1972, and within 6 years, The ESR organizations were amended or added to the Social Security Act. What are the ESR organizations? It was covered again by Dr. Andy Howard. They oversee the safety and quality. They are liaisons between the government and ESR services, because you cannot report everything or anything that happens in your dialysis clinic to the government directly. So you report it to the ESRD organization that cover your area. ESRD organizations have responsibilities including quality oversight, collection of data, and technical assistance. These are roughly half a dozen quality organizations that have the 5-year contract of 18 ESRD networks. And 2026 is the year where they have all to apply for the next 5 years. And we will see in a few weeks or less than a few months which organization have obtained the contract of your ESRD network, your territory of the country. The National Forum of ESRD Network has 3 advisory councils, and this is the org chart for the sake of disclosure and the responsibilities and areas that the National Forum of the ESRD Network is involved. It's a voluntary coalition of 18 congressionally mandated ESRD network organizations. I had the pleasure and privilege to be one of the presidents from 2023, 2025. I'm currently the immediate past president. Our president is Dr. Dan Landry. Our president-elect is Dr. Priti Yeram. Our past president was Dr. David Henner, who put together this wonderful article about the National Forum of ESRD Networks and essentially the history and areas that National Forum of ESRD Network is involved. Now, going back to the medical directorship as it relates to what also the National Forum of ESRD Network has helped clarifying that each dialysis facility must have one qualified physician as medical director. You may say that, does he or she or they have to be a physician? The answer is yes. Does he or she or they have to be a nephrologist? No, but in reality, out of 7,500 dialysis clinics we have in this country, as far as I know, all of them, except for 1 or 2, are board-certified nephrologists involved. What's the implication? In addition to ensuring compliance with CMS conditions for coverage, is that the authority is regulatory, not symbolic. It's not the United Kingdom's Queen of England, where somebody has some symbolic position. No, the position is associated with regulatory compliance, which is authority, but with authority comes accountability. So the medical director is accountable, and to that end, all people who are the member of that entity are accountable, and accountability is exceptionally serious here, as it should be. The active oversight of patient delivery and interdisciplinary processes is among physician leadership. That means the person who is named as the medical director of one of the 7,560 dialysis clinics bears that responsibility. QAPI, running monthly QAPI, staff education, competency, clinical policy development, active leadership in interdisciplinary conferences, if needed, morbidity and mortality reviews. Governing body, what is governing body and what it means and what it entails, and the continuous operational leadership, as long as that person is named as the medical director, as expected by the CMS. So now, in terms of the governing body, the 2 key words are safety and quality. Safety and quality is not even about the staff or the physician or physician groups. It's about patient safety, patient quality of care. Patient safety, patient quality of care. And the governing body is responsible for appointing the medical director. You may say that, is medical director the head of the governing body? The governing body appoints the medical director. It is a dynamic relationship. If we look at here, the governing body's members, the 3 persons are the members of the governing body. Although the definition of governing body is that it could also be one person. But it's highly unlikely you find one person to be to represent the governing body, because unless there is a disaster, there is an earthquake, nobody's left. The governing body has at least 3 members: medical director, again, the physician leadership, the clinic administrator, who is the partner with medical director, and a regional manager administrator, who is usually from one of the dialysis companies. And the responsibilities of the governing body is QAPI, to ensure that QAPI is run, documented, and acted upon every month. Medical staff credentialing, patient safety and rights, staffing. Staffing includes 5 categories of staffing, and we'll have lectures about this: nurses, PCTs, dietitians, social workers, biomed technicians, and other staff. Involuntary discharge policies, which could happen once in a blue moon, but it's a very serious situation. And in some joint ventures, and this is the only time I mentioned joint venture in my talk today, medical directors or local nephrologists may also have a financial stake in the governing body's decision, and this has to be resolved correctly as we go over a number of slides towards the end about the keywords fraud and anti-kickback and other things. Now, what is the role of ESRD networks? Their oversight, as we discussed, ESRD network organizations, they are liaison. The government delegated their surveillance to these organizations so they can watch us in the dialysis facilities. There are 18 of them. They are congressionally mandated. They are contractors, third parties, every 5 years. This year is the year they're applying to CMS to win or lose the contracts, and they oversee the interdisciplinary teams. The ESRD network organizations, as shown here, they have also a number of requirements on behalf of the government that needs to be looked at and implemented by the dialysis facility, including the dialysis medical director and the leadership of the dialysis facility, including, as you can see here, timely submission of EQRS data, formerly known as Crown Web. Data must be entered in a timely manner every week, if not every day. And if you don't have AI or automated system, you have to hire someone to enter manually all the laboratory data and other data, all patient data, grievance and involuntary discharges, educational materials for patients, peer-to-peer mentoring. We must notify the network is a network of major events, facility closure. Suddenly, 2 days ago, we had a flood here, and we had to report that we shut down our third shift, and we had to find other places. So that was that's a requirement to ensure that ESR network 18 knows. And I myself, actually, I have several hats. So I'm in charge of that. That means I have to write a letter probably to myself that, dear Dr. Kalantar, we have to close the third shift because of thunderstorm and flood. Signed, Dr. Kalantar. But of course, that's a joke. I'm not going to write a letter to myself. But these are things that we're going to report to each other. Staffing or supply shortage, we can't just say, hey, we don't have enough those machines or membranes. We have to immediately report to user networks. Threats, if there's a life-threatening situation, patients against staff, staff against patients, if physicians against staff or anybody against anybody. And a few other things that we have to report to the ESRD network. Now, does it work with the surrounding? An example, my own example in Los Angeles County, we have Los Angeles County Department of Health Services, 4 major medical centers, gigantics, the main former USC Medical School Center is part of that. UCLA Harbor is part of that. Valley View, Rancho Los Amigos, more than 20 ambulatory care centers. So, and these patients come and go. Why? Because there are over 100 dialysis clinics in LA County. So a good 5 to 10% of them, they are actually related to these. These patients are covered in panel, and patients come and go. What happens to them when they come to the ER? These dialysis patients from the clinics to the emergency rooms of the health network. hospitalization, discharge coordination, coordinations, transitions of care, vascular access, so many problems. So we work together. We are not separate. All right, now I'm changing this to an interesting topic. Nephrologists. Do we have enough nephrologists in the United States? Do we have too many nephrologists? Do we have not enough nephrologists? Do we have a shortage of nephrologists? The answer is that currently we have 1,200 as of yesterday. When I checked American Board of Internal Medicine, I can tell you it's very accurate. 12,326 board certified nephrologists who are active. Actually, initially we had that 15,000, but some of them, they have not maintained their certification. So they are not board certified anymore. 12,000, so 3,000 are not certified, 12,000 are certified. 17% of US nephrologists have completed training before 1989. Therefore, they don't need, like me, sadly, to take every 10 years. I have to take my board certifications, sit down next to younger and younger people and take the same tough exam and pass it. If I don't pass it, I'm not board certified. So you can check on me. I'm fully disclosed. Please go and check on me, see if Dr. Kalantar is board certified, double board certified, triple board certified, non-board certified, has been under penalty or under certain watch. This is all, the physicians are highly transparent. Fortunately or sad, I would say fortunately, I'm very happy, proud that everything about me and everything about the other 12,326 nephrologists is well known. Nobody can hide anything. Now, how many see patients? Probably roughly 9,000 to 10,000, because some of these 12,000 colleagues, they are doing other stuff. Maybe they take care of children, they take care of big companies, they're in pharmaceutical companies, they're not seeing patients. We're not even sure if there are 9,000 patients who see patients. And if this 9,000 to 11,000, maybe some of them are part-time, some of them just go sporadically, see a few patients here and there. Some of them are running other things. So, and what happens every year? Every year we train 400 to 500 new nephrologists, and 80% of them, they pass the boards, 20% fail. 300 to 400 nephrologists retire every year. Now, do we have exact numbers? No, these are our estimates. I mean, the exact number is 12,326, but who is retiring and who is coming back? This is a highly dynamic environment. To understand us, it's very important to know that it's a tough situation here. There is 5 years of pre-med plus 5 years of medical school. Only less than 2% of applicants are accepted to medical schools, osteopathic or allopathic medicine. Then there is 3 to 5 years of residency, 2 to 3 years of fellowship. And if somebody is smart, hardworking, knows everything, will pass the boards. The rate of passing of the nephrology board is currently 75 to 83%, one of the worst in the nation, in the history. Not that nephrology trainees are not smart, it's a tough exam. So, and to make things even worse, we used to have 50% more applicants than positions. Now we have 40% less. So for each position, we have only 0.6 applicants. So many positions remain unfilled. Now, let's move here. Closure, to add another good or bad news, closure of dialysis clinics. We used to have 7,800 dialysis clinics at the peak of COVID. It's down to 6,500. If I could show here one of the publications, and this is also coming from the National Forum of ESR Network, that we, according to CJSON paper, number of dialysis units went from 7,800 to 7,600, and is currently, or as of last year at this time, was 7,500. We believe that we are around 7,500, so there is no net closure. Now, does it have implications on us? We have to deal with 7,500 dialysis clinics and the quality of patient care, and conflict interferes with quality of patient care. Conflict interferes with quality of patient care. Who said that? My wonderful friend, Dr. Charlie McAllister, who was one of the chief medical officers of a large dialysis organization. How to replace conflict with more collaborative models. Understand physician backgrounds. That's why I spend right now 5 minutes to explain to non-physicians and the physicians themselves, because Sometimes physicians forget what a tough journey they have had to be here. We train to act independently. I shouldn't say we never are trained to have a team approach, but physician, her definition is a person who must make decisions independently. So we are not trained to be part of a team, except for some of us, maybe those who have MBA degree, later on they try to learn that. So is it a boot camp? It's actually worse. To become a physician is worse than that. So just have some respect for these people. They manage to make it and become your nephrologist. Now, does it justify me to be angry? No. No matter how tough my journey was, I may not have unresolved conflict in my dialysis clinic. And I've been a medical director of more than half a dozen dialysis clinics. Patients care suffer, emotional toll on teammates and on patients, implication of dialysis clinics, and litigations, lawsuits, complaints, regulatory bodies, problems after problems. So now, how do nephrologists do as medical directors? 5 less desired behavioral patterns. With all due respect and my apologies, personality number 1, hostile, high-handed, authoritarian, low emotional regulations. Like me, Dr. Kalantar, I always go angry to dialysis units. I say, hey, don't you guys know I don't have time? Don't waste my time. And so I run everything according to the rule of fear. So that's person number 1. Personality number 2, egotistical, self-seeking, know-it-all. Oh, guess what? I know everything. Just listen to me. You only listen to me. Don't listen to anybody else. Or I say that, hey, you know what? That's person number 3, stalling, indecisive. We need more data. I'm not even sure what to do. Let's talk more. Let's pull data. Let's pull more papers. Let's talk. And after 6 months, I'm still stalling on some projects. Personality number 5, number 4, unbending, inflexible. We have been running this my way for the past 20 years. There is no reason for us to change the anemia protocol. And then burned out colleagues. Some of them like me, I'm going to say, hey, I've worked for 25 hours. I'm tired. Just leave me alone. Do whatever you want. And please don't come after me. And don't call me. So let's go over some of these statements. Of course, we are not here to have interactive discussions, but look at here. Just allow the anemia protocol I approve. I don't want any more discussion about this. Which personality is that? Yes. Dr. Kalantar's high-handed personality. I have run dialysis units for 20 years. I already know how to improve K2V. Listen to me and nobody else. Egotistical, self-seeking, know-it-all. Medical director says, Dr. Kalantar says, let's review a bit more data before deciding a vascular access initiative. And I've been saying that for 6 months, and nothing. Everybody's frustrated that Dr. Kalantar doesn't make a decision. Stalling, indecisive. Next one, we have always scheduled shift this way, and I don't see a reason to change now. And then handle it whatever you want, and please don't even call and text me. I'm not available. Now, with the burnt out people, we have programs. Of course, with all of these personalities, we have programs because I feel I always relate to all 5 undesired personality disorders. Now, to make it more positive, most doctors are well-meaning. So please keep in mind that physicians are trained to make independent judgments, so understand physicians. Physicians often respond to facts, give them facts, work with them, and dialysis center teammates should find effective ways to connect with physicians. Mutual help and guidance are needed. So please, I'm not saying that try talk our language, but please find ways that we can communicate correctly with each other. Now, physician leadership is a lot into communications. Communications, let me see the example. For example, we had problems ordering intraperitoneal antibiotics for PD peritonitis. And it just doesn't work because probably All we need to simplify and align the message instead of trying to explain over and over how this works and meeting after meeting. Hey, inject antibiotic in the bag, period, right? And if people want to know more, let's do this first, inject antibiotic to the bag, and I explain to you more next time. But get this done correctly. Clarify, clarity. One of the wonderful chief medical officers of dialysis facility, dialysis company says, clarity is kindness. Always clarity. Less is more. Assume positive intents. If I go angry to dialysis unit, say, hey, you guys again mess up my order for intraperitoneal antibiotics, terrible. It keeps happening. You guys always do that to me. I mean, what kind of medical director am I? Emotionally irresponsible. And one of those 5 categories of personality. Listen actively. When people say that the counter, it doesn't work this way, then I say, okay, so what do you think? What should we do? I should encourage people. As a medical director, I should encourage everybody to work together so it's a team. 1 + 1 is 3, if not even more. And the time commitment, I can't just say that, hey, I'm here. I come here once a month to sign medical director things. And it was terrible. Actually, sometimes I talk with colleagues. I say, hey, can you take care of our dialysis patient? I said, look, I heard you guys have this or that contract, medical director, just give me the medical director contract, and I go there once a month to sign the papers. Is this really the definition of medical directorship? It's terrible if Dr. Kalantar feels that this is the definition of medical directorship. Now, there was an era where my uncle used to be medical director of 8 dialysis units. That era is over, done. History will never come back. If you are dialysis medical director of 1 unit, you should be very privileged. Exceptionally, 2 units, 0.25 means 50% of your time is gone. Be careful here. There is not only accountability, there is not only, authority and other things, but there's also business, but there's accountability. Now go to our toolkits. It's written 0.1 to 0.3 FTE. Medical director contracts, of course, this is the only time I'm going to mention $ here, 30,000 to 150,000 based on the regionality, fair market value. So you guys discuss that with your companies, but this is not where we're discussing this. And the non-compete zone, and what we would like to mention here, and in a few slides, you will see the accountability. The area of accountability is very significant and important. Now, what if I want to work with all these colleagues from DaVita to Fresenius to US Renal and DCI and other satellite and other things? Well, guess what? You want to be medical director, or you want to even non-medical director going to different units, you better be sensitive to the different cultures. Like in DaVita, clinical administrator is called FA. In Fresenius, it's called CM. In US Renal, it's called FA. But then in US Renal, the care team meeting is not called plan of care, which is called at Fresenius, but it's called the interdisciplinary meeting in DaVita. So I usually encourage people to have a vocabulary of different cultures and terminologies. The worst would be that you go to a Fresenius clinic and use US Renal vocabulary or vice versa. So be sensitive about these things and show respect, because the teammates are not working in all dialysis clinics. They usually work in 1 or 2 of these, most of the time in one of these dialysis providers. Now, the dialysis medical director is going to sign attestation. And this is not just a check marking every month. It says, as medical director, I serve as member of the clinic governing body as an assessment of care planning. I hereby attest that I serve as clinical leader, admission process, safety, patient's right, confidentiality, safety and quality of water, and infection control. And all these things, I click, and I submit. I better have done this. I'm warning myself that this is very serious area of accountability. And with that comes here the keyword, anti-kickback statute. Wow. Anti-kickback statute, AKS. Have you guys watched the movie? Actually, I don't think there's a movie. It was a joke. If there's a movie, hopefully in the future, there will be about a dialysis medical director who listened to my talk and had nightmares about this and couldn't figure out what it is. Actually, that's myself. Medical director expectations are defined by medical director agreements and the conditions for coverage. Governance principle. Facilities must demonstrate that medical directors actively fulfill contracted clinical leadership and oversight responsibilities in accordance with regulatory and organizational standards. To avoid anti-kickback statutes, also known as Stark Law, medical director compensation must align with the documented performance of defined leadership duties. I can't just say that, hey, Dr. Kalantar, you're very important and you give lectures, you publish papers. Dr. Kalantar, you don't publish anything and you're not important, but you refer a lot of patients to us, so we want to make you medical director. Or Dr. Kalantar says, hey, I'm going to refer 100,000 patients every year. You better give me 5 medical directorships. Anybody who talks this way or think this way, guess what? If there was an era, there was never an era, by the way, because for the past 53 years, anti-kickback has been governing and regulating what we do. The keyword here is fraud, waste, abuse. Fraud, waste, abuse, anti-kickback statutes, false claim acts. And if we fail to comply with these laws and regulations, we may subject to civil criminal liabilities. And when I say criminal liabilities, I'm not here to exaggerate. It's a crime to have violation of any of these things. Crime means that you will be implicated. You may even go to jail, as some nephrologist has been arrested. A very renowned nephrologist has been arrested. And I'm very fortunate I was not me, but one day it could be me or anybody who is listening to me or in the future is listening to me, or it could be also myself. So anti-kickback statute is a federal law designed to prevent fraud and abuse in the healthcare industry by prohibiting the exchange of anything of value to induce or reward referrals for service covered by the federal healthcare programs. Now let's go over some of these things. So what do you think? So let's choose between False Claim Acts, FCA, versus Anti-Kickback Statute, AKS. Prohibits knowingly submitting false or fraudulent claims for payment to the federal healthcare programs. Now, just remember, this is not just medical director, the entire dialysis clinic and governing body, everybody and regional directors involved. Requires accurate documentations, coding, and billing only for services actually provided. So if I not see patients and put in physician corner FMC or 1B of DaVita or that of US Renal that I've seen patients, that is wrong because I have not spent time with the patient. Enables government investigation and recovery of losses due to fraud. Prohibits offering, paying, soliciting, and receiving anything of value to influence referral for services. So I may not receive a very expensive gift at the end of the year. Applies to financial relationships, compensations, arrangements, referral-related interactions. Require that medical director agreements reflect fair market value. You guys cannot give me suddenly $299,000 because I'm very famous. I give another nephrologist $32,000 for the same medical directorship. So this is False Claim Act, and this is Anti-Kickback Statute. And I apologize for being a little bit this picture. So think of me. That's my face being arrested. I don't even know who that person is. Is a model, is not a real doctor. But why this matters for the dialysis medical director? Because medical director compensation must correspond to documented leadership services that are truly rendered. Clinical administrative activities must be real, necessary, and performed. It may be real, but not necessary. I can just go there and say, hey, how are you? By the way, I'm just here to show myself so that you guys have seen me being in the medical, in the dialysis clinic. Financial relationships must avoid referral influence. All right. Wow, that was too much, right? Okay, take a deep breath. All right. Now it was, we are going to switch to another subject for 1 or 2 minutes, but I'm not going to talk about this. Why? Because it's like a preview of inpatient dialysis services. We only talk about outpatient dialysis services. Why? Because outpatient is under the federal government. Inpatient is differently arranged. There is no clear-cut regulation, but we, at the National Forum of ESR Networks, we have put this together. We published a number of years ago on this. We have a toolkit for this. It's called inpatient dialysis. Sometimes it's called acute dialysis medical directorship. And a few things that, in contrast to outpatient dialysis facilities, the inpatient condition coverage is not about inpatient or acute dialysis operations. It's a much higher level of complexity. There are CRTs, ICUs, AKIs, although AKIs has now an overlap with the outpatient dialysis clinics, and areas that are not overseen by CMS. So if you would like, but it is overseen, or at least to some extent is being watched closely by the Joint Commission, formerly known as JCO, but those who still call this the TJC JCO, they should know JCO is more than 10 years ago. It's now called TJC. But TJC comes to your hospital once a year or more frequent, less frequently. So that the first places they go on day 1 or day 2 is your dialysis operation. We talk about more the differences between inpatient and outpatient medical director. If you join us in Kansas City, Priti is very happy to see that I'm showing preview and giving a lot of promotion to annual dialysis conference in Kansas City in 2 weeks from now. And we'll go over this wonderful chart of inpatient dialysis medical directors reporting to the chief medical officer of the hospital, not to the ESR network anymore, and how this is run correctly. And if you would like to know more, please look at our inpatient dialysis medical directorship toolkit. You will see a lot of wonderful, important chapters here, as you can see here. Now, the last 5 minutes of my talk, I'm going just to go over what you will see in the next 7 sessions, because we have 9 sessions and running session number 2. Medical director, infection control, water quality, ESR networks and patients, leveraging QAPI, emergency and disaster preparedness, and then home dialysis, value-based care models, and effective rounding in dialysis units. Infection control, wow, I mean, nothing is enough. The more we talk, the more we lecture and training, any service we need in infection control. So you will have a wonderful lecture on this in the next few weeks. Water quality is the one that a medical director must know from inside out. If you are a nephrology fellow and you don't know about these things, don't worry, because you're supposed to know. So it's a requirement. So study a lot. And once you become medical directorship, hopefully you will catch up. The patient-provider conflict is a very important area of medical director responsibilities, grievances, pathways, involuntary discharges. For example, as the chair of the medical review board of the Network 18, I've had the privilege for past 8 or 9 years. I'm very sensitive about involuntary discharges, and I will make sure that patient has exhausted all options. I'm not saying that I'm biased towards advocacy for patients, but patients have usually the right. So we better be very careful about involuntary discharge, but we'll discuss this next during one of the sessions. QAPI process. QAPI stands for Quality Assessment and Performance Improvement. It's every month, and it's not just a meeting to go and have sandwiches and coffee. And I have my coffee here. But to document and to act, because this is essentially one of the components of the conditions for coverage. Management of emergency management and disaster preparedness. As I said, in LA, we had a number of thunderstorms over the weekend, and some dialysis clinics, including our own dialysis clinics across the hospital where fellows are trained, was affected, and we had to close one of the shifts. And we're so fortunate that we managed to open and things safety, because safety comes first. When, as your flight says that after 4 hours of delay, and they don't even give you any reimbursement for your 4-hour delay flight, I said your safety comes first. But this is here not lip service. The safety of a patient comes first. Home dialysis value-based care models. This is the era of home dialysis. We're very fortunate. We better push for more home dialysis, but correctly, not coercing patients. That is wrong. I will discuss more about this. And when you come to ADC, rounds in dialysis facilities, how I go and see these patients. Should I wake up as sleeping patients? Should I continue to let the patient sleep? Should I talk to the patients in front of others? Should I talk in Spanish, in Tagalog? Should we talk different language in front of patients? If we don't speak English, if patient thinks that we're talking in a different language about them and smiling, is it good or bad? So many important things about this. And please, if you would like to know answer to some, if not all of these questions, download our outpatient medical director toolkit, and Kelly is going to remind you that when you do this, please appreciate what Kelly and others have done here. And with that comes my last slide. Key take-home messages. CMS conditions for coverage establish the dialysis medical director as the central clinical leader responsible for quality, safety, and regulatory compliance. Quality, safety, regulatory compliance. If I go as medical director and I am not compliant, if everybody has to have a gown and I say that I'm more important and I continue to have my black jacket during rounds, then I am not a good role model for regular compliance. And with regular compliance comes also compromising safety and quality of care. Statement number 2, effective dialysis governance links the governing body, medical director, interdisciplinary team, and ESR network oversight into a continuous QAPI feedback loop. Monthly QAPI. QAPI, or quality assessment and performance improvement, is the key, is an important operation. It's monthly. If you guys think that I can attend this while I'm driving from dialysis to dialysis, I'm not even there, and I'm a covering medical director, I'm not there, I better know what I'm missing. Medical directors must actively lead core domains, as you will listen in the next 7 sessions: infection prevention, water safety, QAPI, conflict resolutions, emergency preparedness, modality strategy, and clinical roundings. Physician behavior and communication strongly influence team culture, conflict management, and patient outcomes in dialysis facilities. If Dr. Kalantar is burned out, I better see a therapist, because dialysis unit teammates are not victims of my personality disorders. If I'm used to yelling at people everywhere, or if I'm used to manipulating people, if I'm a egocentric person, I better have some control over those things before causing more problem and more suffering for others. Number 5, medical director time, accountability, and compensation must align with the documented leadership duties to meet the regulatory, and I'm not going to use them because I noticed some faces were very stressed out when I said FCA and AKS. But guess what? You need to deal with FCA and AKS, and you need to be careful. All of us, from medical directors to community nephrologists to rounding nephrologists to teammates. Why? Because we are accountable, and our compensation must be according to fair market value. High reliability dialysis care depends on engaged physician leadership. Physician leadership must be engaged. If there is a disaster in my dialysis unit and I sit down at home over the phone, I say, okay, let me just text me or send me some of the pictures. Let me see how things are. A few times I changed my flight. I was at the gate. They told me there is a question at the dialysis unit. I walked from the gate back to the dialysis unit. And this is, hopefully, I'm sorry, this is actually consistent with personality category number 2. I'm bragging about myself. So I apologize. I should have not said that, but we should do this. We should consider being engaged and authentic leader of the dialysis facilities. Closing statement. Physician leadership is not symbolic. This is not Queen Elizabeth or King, whoever it is now, to go and show myself and smile and have some photos and have some pizza every 6 months. It is regulatory operation. It is patient-centered, and it is standards. And a good leadership, strong medical director translates standards into practice, teams into performance, governance into better outcomes. Together, we team up to serve our patients. Why? Because 1 + 1 is 3, if not even more. With that, I would like to acknowledge all the colleagues who have helped me at UCLA, UC Irvine, and ESR Networks, and so many great places. And thank you very much.
Kim, thank you. What a great talk today. We expected nothing less. We knew, as always, it's a wonderful show, and in the sense that you give us so much incredible information. I'm looking here and have a few questions for you, if you don't mind. I think we still have about 10 minutes. One important question, and I think one that resonates with all of us here at the forum, is a question regarding the decreased number of dialysis clinics. And your thoughts about any potential or reasons, or if in terms of why we've seen a decrease in some of these numbers.
Okay. Yeah. Actually, Dan, my suggestion is please put your colleagues who are not asking questions, please put yourself on mute.
So it comes through the phone.
And now, Dan, these are real world scenarios. That means I have been around for 25 years as medical director, and in the United States, not to mention also prior to that in Germany, I was doing moonlighting in dialysis clinics so altogether, I would say 30 years, and I've seen so many good things and less good things happening. And I think physician leadership here is the one that is being judged on a daily basis, if not hourly basis. So now, also, then I think some colleagues have put some questions or comments here. Would you like to go over some of them, or I can read them?
Yeah, I'm happy to, Cam. There was really a nice question here regarding, in terms of just exposure. It was in our program we're using, let's see here, forgive me. Any tips on how to involve fellows or residents in governance and other aspects of medical directors' workflow? Also, are there opportunities for them to learn network activities?
Okay, all right. So let me make sure actually we have shared things. So that's wonderful question. Actually, to the credit of large dialysis organizations, they have now allowed, there was a time where it was very difficult for fellows under training to be part of the dialysis rounds and dialysis medical directorship, and it was more like an elective for nephrology fellows. But now some programs, including ours, we have made it mandatory. It's not elective anymore. It's a 6 months out of 24 months of rotations in the dialysis unit. That means the fellow, 6 out of 24 months, must sit down in the dialysis clinic. It's similar to European or Asian systems where at any given time there is a fellow sitting there. And as far as I know, many programs are doing that now. That means at any given time, there must be 1 or 2 fellows sitting there and being involved as if they are part of the team. And that's probably the best way to learn, to join almost all rounds, to see, to watch, to attend the QAPI meetings. So that's probably the best way to watch. For example, I was rounding last week, and we were watching a patient who was not happy, a patient who was, patients are wonderful, but we have to understand that they're sometimes unhappy because they have difficult time. Now, if they use F word for me, I understand them. F word, S word, so many things. So if you're a nephrologist and sensitive on F word and S word, you better not be a nephrologist. So I take the fellows with me so that they see if Dr. Kalantar can hear those words and still smiles. So that is expected from them. I'm not saying that part of the training is emotional control, but it is actually an important part of that. So I feel that nephrology fellows must be hands-on involved in the dialysis clinic day-to-day operation. And the other companies, including the Vita, Fresenius, US Renal, DCI, to their credits, they all have created now ways for dialysis fellows to get privileges and to even write notes. So I don't know if, for example, yourself, Dan or Don, you guys have any other observations, suggestions of how fellows in practice can be involved, or how we can ensure that training goes to that direction.
Yeah, I think, Cam, you said it well, of course, and I think one of the things that we've tried to do out here in Springfield, Massachusetts, is I think make sure that there's a focus on the opportunity to witness what a medical director does, and not have it solely focused on rounding on how many patients you can see. And I think to that end, I've encouraged our fellows and tried to have them in part of our QAPI meetings when possible. And that kind of engagement, that type of just listening, is I think a critical factor to really understand, what our responsibilities are to our patients and to our staff members.
Yeah, and Don, maybe I'm going to ask Don, because first of all, Don, these lecture series are in your honor and your name, and I'm privileged and honored to deliver one of the 9 lectures of Don Maloney's lecture series on behalf of the ESR Networks, or National Program of ESR Network. And Don has been involved for the same, if not longer, amount of time in training of fellows and future nephrologists.
Well, it was a great talk, and I think that you highlighted the challenges that a good medical director should confront, both their own in strengthening their own approach to their peers and to their coworkers and to the patients to be effective in their communication. I think that we really do have to strengthen the way in which we bring fellows into the outpatient dialysis, because that's such a key part of our management of patients, but they don't really see that. And then what they do get is a little bit too dry. And I think attending QAPI and the various oversight committee meetings helps them probably appreciate more than anything else the complexities of infection control and management of solutions and other quality preventative measures that the medical director and the nephrologist working with the medical director need to pay attention to. So it is a big challenge. We don't quite do all of that yet, but they do. Every month I have a fellow rounding with me on all my dialysis patients, and he or she takes the charge with the patients, and then I'm standing there so the patients know that I'm still part of their care team, and we model it. But I've learned something here tonight, and I'm going to try to expand their exposure to some of these other opportunities to learn in the outpatient dialysis setting. Thanks again. Very nice.
So thank you. I'm honored. Don and Dan, one question here is there a limit to number of patients or clinics a medical director can serve? As far as I know, no, there is no limit. But hopefully I don't have 200 or 300 patients, because eventually somebody is going to find, if there's a problem, somebody is going to look at me and say, look, is that true, Dr. Kalantar? 222 patients were under you in December of 2025. How can you even manage that, plus being medical director? And this is so we better self-regulate ourselves. That was one question. The other one, so no, there is no number anywhere is written, and it has to be done correctly. As medical director, what do you do if nephrologist does not see their patients? So that's a good question. First of all, I better see my own patient, because medical director also is a nephrologist. So first I correct myself, then I go after others. I say, hey, Dr. Jackson, I've heard two of your patients, they don't even know you because they have not even seen you in the past 2 years. So can you please go and say hi to your patient? Yeah, we have to find very delicate but effective way of communicating. I can't be too sarcastic. That's terrible. But yes, if that, it has to come to the attention of the medical director. And the best is that the FA, the nurses, when they have a patient who is complaining, I have not seen my nephrologist for 2 years or 2 months or whatever, it goes to FA. Please be careful about implicating the nephrologist. First, talking to your FA or clinic manager talks to medical director finds a way to bring this back to the nephrologist, right? So that is usually as among the also physician leadership pearls or caveats. And then another question, medical director's workflow and other things. So please refer to our outpatient medical director toolkit as well as other toolkits.
Thank you, Kam. That was fantastic. We have just 1 minute left, so I'm going to ask you one last question, if you don't mind. You've mentioned, of course, many things that as a medical director, we have a lot of obligations to responsibilities. But what is it that really that you love most about being a medical director? Because I could talk for a long time about the things that I love, but what about you?
Okay, I wasn't prepared for that. So can I say the best coffee that I get during coffee? I always look forward to that. One is coffee, and the other one is sandwiches because they have egg white sandwiches. They order for me because they know I don't eat meat. But no, that's a good part of that. But the best part is when we sit down and enjoy interactions with teammates. When you see a teammate says that, wow, this patient was so appreciative. That patient, when a patient passed away, the other two patients, they cried. I mean, these are stories when you hear them. When you hear them directly from the patient, so you hear these wonderful stories from others, directly or indirectly, then you say that, wow, this 25 years I've been practicing nephrology in the United States after my fellowship, I really felt that I have been blessed. And being a medical director, being privileged and overseeing all these things in different dialysis clinics. But thank you for asking that question.
Thanks, Kim. That was terrific. And again, we just want to say thank you to everyone for being here today. You may have seen in the chat that Kelly left a link, a SurveyMonkey link for feedback. We really would love to hear your feedback. We want to continue to not only make this a successful webinar, group of lectures, but also something we're more than happy to kind of try to improve upon to make sure we're getting people what they need. But again, thank you, Kam. Dr. Kalantar, for this wonderful talk today, and we hope to see everybody back at our next talk.
Thank you.
Thank you so much.
Thanks, everyone. Have a great night.